So what is known between inflammation and Parkinson's that have linked these two things together? Well, first, inflammation's been linked to Parkinson's through genetics. LRRK2 and Parkin, which have been linked to an increased risk for Parkinson's disease, play a role in the immune response to things such as tuberculosis and leprosy. And mutations in immune mediators have been linked to certain cases of familial inherited Parkinson's disease. So through genetics, we're starting to understand that inflammation may play a role either on its own or in collaboration and synergy with some of these other mutations that patients may have. We've also linked inflammation to Parkinson's through epidemiology studies. There have been reports that chronic use of select anti-inflammatory medicines have been associated with a reduced risk for a secondary Parkinson's diagnosis. We've linked inflammation to Parkinson's through pathology studies as well. We see an increased presence of activated microglia and cytokines in post-mortem Parkinson's brains and CSF. And we see that inflammation is linked to Parkinson's disease through animal model studies as well, with various Parkinson's models having a neuroinflammatory component. And if you interfere in that inflammatory process, you can reduce degeneration as well. So we know inflammation may be related to Parkinson's, but why is it so important to investigate inflammation in PD? Well, first, as I said with the genetics portion before, there's a potential overlap with the usual suspects of Parkinson's disease, such as these mutations in LRRK2, Parkin, GBA, alpha-synuclein. And that leads to the question, does modulating inflammation affect PD-related targets or vice versa? So can we either impact these different targets and that may have a role on inflammation, or can we interfere with the inflammatory process going on and then have a better outcome for these mutation carriers? The immune system may be an environmental modifier of Parkinson's disease, maybe through epigenetics or cumulative risk. Maybe it's a multi-factor hit that leads to Parkinson's disease in the cases that are idiopathic, or the cases where patients have mutations and some go on to develop the disease, whereas others do not. There's a potential for a disease-modifying therapeutic development as well, if we understand if inflammation is either causing Parkinson's to progress or contributing to the pathology as well. And for this, we can take a page from the MS playbook, hopefully, and kind of learn from what other fields are doing as well. And then, of course, inflammation is automatically biomarkerable. It's a secreted factor. There are markers on the outer cell membrane. You have peripheral readouts of inflammation in certain cases. So if we can understand the immune signature of Parkinson's disease, hopefully this will help us develop biomarkers that can help clinical trials choose patients for the right studies. Maybe we can use these biomarkers to help diagnose PD earlier and start interventions before pathology has increased to the point where motor symptoms develop. And as well, maybe we can use these biomarkers to see if a therapy is slowing or stopping or reversing disease progression. And this would be a really good readout for trials so they can be shorter, more focused, and we can have better readouts of efficacy. So the MJFF strategy for investigating the role of inflammation is threefold. First, we want to identify the PD immunophenotype, and we have key questions and challenges within this area. First, what is the PD-specific signature for both neuronal and peripheral inflammation? Are these different? Can you use peripheral inflammation as a readout of what's going on in the brain, or are they two separate components that need to be kept separate? Also, there's inherent variability and challenges for rigor and reproducibility with measures of inflammation. They can change and variate and fluctuate between times of day with circadian rhythms. They can change based on, if that patient's been exposed to the flu or things like that. So there are some certain issues and variability that we need to address in this field. So our strategy for looking at this is funding various labs to investigate inflammation using different assays and different readouts. We're convening an advisory committee to help guide us on the role of inflammation in Parkinson's disease and bringing non-Parkinson's inflammation experts into the fold to try and understand what other groups know and how we can move forward. We're looking at the role of chemokines versus cytokines. What's the impact of acute inflammation versus chronic inflammation in this disease? And should we focus more on one than the other? And finally, leveraging information, methods, and tools from other fields like the MS field to try and piggyback off on what is learned and what tools they have so we're not starting from scratch. Second, we're looking at inflammation biomarkers, and the key questions and challenges here are issues in translatability. If you're looking at animal models, the immune signature is very different than in patients in a lot of cases. Models are kept very isolated, microbiome is different, things like that. So really understanding how to move between species and how to understand what's going on and how you can interrogate these pathways. There's also a possibility that you may need to optimize new collection protocols based on what your readouts are. Are banked blood samples going to be the best if they're frozen, or do you need fresh collections, things like that? And we need to look at the possibility of developing companion biomarkers and integration of validation to see maybe how readouts of inflammation can be used with other readouts for Parkinson's to kind of get a more holistic look and a better feel for what's going on. And our strategy here is we launched a focused inflammation biomarkers RFA in 2017 as a call out to try and get groups to come to us with their ideas. We fund human biospecimen sample collections as well as cohort studies to try and bank samples to use in the future. And if we do need special collections, we will also do that as well. We prioritize companion biomarkers looking at inflammation in aging, phenoconversion, and microbiome studies, as these may all be very important in Parkinson's disease. And finally, we also have a lot of non-funding initiatives going on. So the questions and challenges we're addressing here are how can we leverage lessons learned and best practices from other disease areas, and how can that relate to Parkinson's disease as well? And then also developing quality imaging tracers and tools for inflammation that are lacking or not standard in the field right now. So our strategy here is to leverage knowledge sharing across disease areas to try and learn from each other. We're initiating consortia with other foundations to address broad field-wide challenges, such as the need for better tools or imaging markers. And we're generating new tools and curating information for animal models to help the community learn about this, what is known, and where to start when looking at this pathway. So our strategy is focused on implementing a strategic funding plan across targets, biomarkers, and therapeutic development by working with various groups to address these key questions and challenges. And important for today's talk is focusing on these two areas within identifying a PD immunophenotype and inflammation biomarkers, where we're working with Abcam to both, as funding their lab as one of our various labs to look at inflammation using different assays, as well as using our patient biospecimens that we've collected through our cohort studies to kind of move the dial forward and get the tools in the hands of the investigators. And with that, I will pass it over to Anlas to go over our assay.